Helmut, can I ask you to come up here, please? Dr. Helmut Kloos has been a member of Community UCC, previously College Community Congregational Church, since 2006, and before that, Zion Congregational Church. Helmut is well known to those of us who have worshiped here for some time, lesser known to those who are newer to our fellowship. Before he speaks, let me share just a few insights into his accomplishments. Helmut is a graduate of California State University, Fresno, first earning a BA in German literature in 1968, then an MA in geography in 1974. Helmut earned his PhD in medical geography from the University of California, Davis in 1977. Much of Helmut's work has been done in Ethiopia, but his research and overall contribution has a much broader scope. His published work covers a range of topics such as an in-depth study entitled Valley Fever, Changing Concepts of a California Disease, published in 1973. Much more recently, in 2020, he released an assessment of the COVID-19 epidemic in the United States with an emphasis on racial and ethnic groups. Also during the COVID era, Helmut co-published an article addressing violence against women in an Ethiopian town during the early phase of the COVID-19 pandemic. Broadly, Dr. Kloos's work falls into 4 categories: field research for his doctoral dissertation, consultancies with various international organizations, teaching at Addis Ababa University, and mentorship and support of Ethiopian graduate students, including collaboration with senior researchers on their projects. Helmut? Hi. He disappeared. We look forward to gaining insights into inequities in vulnerable communities.
Thank you, Pastor Julia. Good morning.
Good morning.
I've been looking forward to give this summary of my research career with a focus on health inequities and environmental insults. They've been guiding principles in my work. I joined CUCC in 2004 with Zion, when Zion Church merged with CUCC, and I plan to stay here as long as I can, because this is a loving, caring church that advocates social justice, environmental sustainability. Social justice includes health justice, because health is also a human right. The Center for Disease Control works or defines health justice science as an approach to provide methods to better monitor, plan for health services, and encourages studies to overcome health inequities. I'm a medical geographer and have worked for many years also in epidemiology. Both disciplines are related and really focus on discerning, studying differences, the socioeconomic differences in health and health distribution. I lived 10 years in Ethiopia, 8.5 years with my wife Diana, 6.5 years with our children. Jasmine, who has joined us today, really making my Father's Day. Ethiopia, as many other developing countries, are facing major challenges in achieving health equity. Actually, health equity has not been achieved anywhere, not even in the United States, as we all know. But it's a goal that all nations are, or almost all nations are working toward. Major problems in Ethiopia are above all poverty. For example, the Ethiopian government spent $83 per capita for health in 2020, when the US spent $10,200. So there are few health services. Health services are deficient. On the other hand, there are widespread diseases, severe diseases, tropical diseases, and increasingly chronic non-infectious diseases because of changing lifestyles, more westernized lifestyles. And there's inadequate disease reporting. And health or births and deaths were not recorded until 2016. No records. So clearly, these deficiencies, these inadequacies in statistics have major implications for health planning, health monitoring, and are not easily overcome. There are major cultural, you can say, cultural disease or illness perceptions and practices that hamper the development of disease control programs. And urban-rural differences are stark, with rural socioeconomic and health levels being low, deficient. I first went to Ethiopia in 1972 at the invitation of the late Dr. Aglilu Lema, the head of the Institute of Pathobiology, to study schistosomiasis, the epidemiology and geographic distribution of this disease. Schistosomiasis is a parasitic disease that is transmitted in water, lakes, streams, etc. Not by drinking, but the parasite burrows through the unbroken skin. And it affects some 200 million people worldwide. It's a priority disease of the World Health Organization and of the Ethiopian government, largely because it is spreading in irrigation systems and other water development projects. Now, a major finding of my dissertation work was both social inequity and environmental injustice committed against certain populations in the Rift Valley, where I was studying irrigation schemes and the diseases, schistosomiasis in the irrigation schemes. First of all, the irrigation farms provided habitat for the first time in this area for the host snails, the aquatic snails that transmit schistosomiasis. And the irrigation farms depended on migrant labor from the surrounding highlands. where schistosomiasis was endemic. So the farm laborers brought the parasite into the irrigation farms where the snail was now thriving. And the two together, of course, caused the transmission of schistosomiasis for the first time in this lowland area. And the local indigenous pastoralists became infected. Not only that, they had been evicted by the government from their prime grazing areas and resettled on those irrigation farms. In addition, the construction of a hydroelectric dam on the major river, the Awash River, upstream, caused cessation or reduction of the floods, the annual floods that sustained the wetlands, and caused, therefore, famine conditions, drought famine conditions for the pastoralists, while on the other hand, the irrigation farms produced food and did not experience these conditions. After completing my dissertation, I carried out consultancy work with international organizations. With the World Health Organization and the late Fred Dunn of the University of California, San Francisco Medical Center, I developed methodology and an exposure index to identify individuals at risk of contracting schistosomiasis, and used that index in Egypt, Kenya, and Brazil to identify high-risk populations. With the Ministry of Health in Egypt and USAID, the Agency for International Development, I helped evaluate epidemiological research in the Egyptian National Schistosomiasis Control Program, the largest control program worldwide, except outside of China. And this program significantly reduced the prevalence of schistosomiasis, especially in the rural areas, which had been neglected until then. With the Ethiopian Ministry of Health and the late Dr. Zain Ahmed Zain and other Ethiopian researchers, I prepared the first book on public health in Ethiopia. The importance of this book is that it gives Ethiopian researchers a sense of ownership that they now understood and could advocate for the control of diseases better than in earlier times when books were used, books from the industrialized countries, expensive books prepared to a large extent by non-Ethiopians. I returned to Ethiopia in 1983 to teach medical geography, research methods, and several other courses. Trained 3 students in medical geography at the master MA level, guided more than 2,000 undergraduate students in their research on the accessibility and utilization of 26 hospitals, health centers, health posts, and 6 pharmacies in Addis Ababa and other towns and in rural areas. These students gathered data on the place of residence and where patients were treated. More than 300,000 polyclinic patients, outpatients, inpatients, antenatal, clients and sick children. We did also, or they did also, interviews on the type of disease these people came to those facilities to be treated. Now, the findings were that patients living far from health facilities had little access to health services. Now, this is expected, of course, but there are some twists to it. For example, females and young children had the lowest utilization rates in those facilities because of cultural restrictions placed on females traveling outside of the communities, not allowed. They had to be accompanied by family male members. So many pregnant women, sick children, did not reach the health services in time. And this contributed to high maternal and infant mortality. We also found that many patients with mild diseases like common colds, intestinal infections, went directly to hospitals if they could afford to go that far, rather than using local health posts and health centers meant to take care of these conditions. But the problem was that these lower level health facilities often lacked drugs, and the quality of their services was lower than in hospitals. We did supplementary household health surveys in Addis Ababa and several other towns and rural areas using random samples. We have a statistician with us, Robert, with whom I've already discussed the pros and cons of doing survey research and sampling. So here we had random samples, representative samples in these communities that gave us quite good, reliable data on health needs in the total population. And some of the findings were that, as expected, poorer people had lower access to the health services. And also that poor people tended to stop treatment, not complete the prescribed treatment regimens because they wanted to save the remaining drugs for anticipated future disease episodes. Now, this practice results in drug resistance. In other words, the parasites or the bacteria, viruses that are not killed by the drug regimen, by the limited drug regimen, then are passed on, surviving and being passed on as drug-resistant organisms. The activity I continue until now is mentoring and supporting graduate students in writing their thesis and dissertations and collaborating with senior researchers. Among the numerous topics studied is high morbidity and mortality from diarrhea among under 5-year-old children. Diarrhea is, besides pneumonia, the major killer of infants and children in developing countries overall because of lack of sanitation, water supply, especially in rural area. So we have again a health inequity that needs to be addressed by the Ministry of Health. A study of the destruction of macroinvertebrates and diatoms in streams because of sewage emitted by towns is an environmental insult because diatoms are a unicellular organism at the bottom of the food chain, and so it is essential for the health of aquatic ecosystems, because higher organisms depend on diatoms. And there are no sewage plants in Ethiopian towns. There's only one sewage plant in the capital city, and that covers only part of the sewage emission in that city. Not only sewage, but also coffee hulls that are washed and disposed into streams had the same effect on macroinvertebrates and diatoms. So next time, or before you go to Starbucks, you want to keep that in mind, that you're really contributing to destroying the ecosystem in coffee-producing countries. It's not only Ethiopia that produces coffee, of course, many other countries do too. So this was a case of environmental injustice. With 4 other Ethiopian colleagues and friends, I helped prepare a book on the community development projects these 4 professors undertook in their home communities where they grew up, building hospitals, clinics, schools, a bridge, safe water supply, and latrines. I've not come across this approach in my readings. Highly recommendable, of course, and it's evidence that Ethiopian academics are not aloof about the socioeconomic problems their communities face. Now, back to Fresno. The big question, of course, being how can we address health inequity and environmental injustice as a church? First of all, we have to remember that there is a north-south divide, socioeconomic divide in Fresno. The rich north, the poor south. One of the changes that have to be made by the city is providing more parks, playgrounds, and art venues in the south to reduce the risk of youth joining gangs, reducing violence and drug use. We can also advocate for high-density housing to limit freeway construction to reduce air pollution. Of course, this has been on the ballot and has been discussed already. Also, health policy is needed to better protect the health of migrant farm laborers who are exposed to pesticides and herbicides, which cause cancer. Overall, the health of rural America now is worse than urban America in most cases. Now, besides policy changes, and advocating for policy changes, our personal lifestyles can be and should be changed in various ways. First of all, we should eat more sustainable foods, more vegetarian, vegan foods. I was inspired by my family. My daughter Jasmine, Benjamin, dedicated vegetarians. For example, 1 pound of beef requires 1,800 gallons of water. This is not sustainable in an environment where drought will become more pronounced and water more scarce. And cattle also produce methane gas, which is much more potent as a greenhouse gas than carbon dioxide. Card number 7. We should drive less, walk more, ride more bicycles. We have an advocate here, Robert, an enthused bicyclist, to reduce air pollution. Also keep an eye on electric vehicles. Solar electric vehicles are now starting to be produced with much better higher range between recharge. Also, the battery disposal problem still has to be resolved because batteries are highly toxic. Reduce our styrofoam and plastic use. Coffee cups, drinking straws, packaged goods. Keep in mind that an estimated 100 million tons of plastic are now in the oceans. And the US is producing 42 million tons of plastic every year. And the US has not joined the Basel Convention, eliminating the transfer of plastic to developing countries. My wife Diana reminds me that laundry soap is highly toxic, containing high levels of phosphate salts, which can contaminate drinking water and lead to eutrophication, which is excessive plant growth and decay in aquatic systems that cause the depletion of oxygen and the death of aquatic organisms like fish. We should use fewer products overall to reduce dumping in landfills, which leach chemical toxins into the groundwater in rural areas. And lastly, we should reduce our use of manufactured pesticides in our gardens. Use environmental friendly methods instead. For example, you can serve the snails beer, which will cause them to die in inebriation. And use plants like marigold, lantana, citronella, lavender, and other plants which all are insect repellent. We don't have to depend on manufactured pesticides and herbicides. I think I'll stop for here and be glad to answer any questions you may have, and want to thank you for your attention.